Good afternoon. Very excited about this masterclass. We've got two legends at the moment looking at what's going on with COVID, and the masterclass is going to be focused on managing COVID-19 risks in the workplace. The panel is Professor Mary-Louise McLaws, very well known to everybody, and Michael Tooma, who's the managing partner for Cloud & Co., as well as Jonas Blackmore, our senior legal writer in the employment space. Before I start though, I'd like to recognize our place in country. And we've actually, as part of LexisNexis, done quite a lot of work looking at how we acknowledge country. And we've gone through a journey, which is exciting. And part of that is also to say that we actually introduce ourselves first. So my introduction is that I am South African, as you probably can hear, with Dutch, French, and Huguenot descent. And I'm also a British immigrant to this beautiful land, Australia. But I do stand in Gamaragal land in Darug country, and I'd like to show my respect to the traditional custodians of this land, of elders past, present, and emerging, and also to acknowledge wherever the elders of your land stand, because obviously this is a virtual meeting. So first up, we have Mary-Louise McLaws. So Mary-Louise is a professor of epidemiology, hospital infection and diseases control at the University of New South Wales. She's also Deputy President of the University of New South Wales Academic Board and Water Health and leader of the Global Water Institute. In February 2020, she joined the World Health Organization, Health Emergencies Program Experts Advisory Panel for Infectious Prevention and Control Preparedness, Readiness and Response to COVID-19 and the WHO Health Emergencies Program Ad Hoc COVID-19 Infection Prevention and Control Guidance Development Group. And prior to Mary-Louise's very well-known work in COVID-19, she was also World Health Organization advisor to China and Malaysia during the development of their surveillance for healthcare-associated infections. She was an advisor on several WHO global projects, including the WHO First Global Patient Safety Challenge, Clean Care Saves Lives, and she reviewed the response in Hong Kong and Beijing to SARS in 2003, which in hindsight is a great lesson for COVID. Welcome, Mary-Louise. It's great to have you on the panel.
Thank you very much.
Second on the panel is Michael Tooma, who's a partner at Cloud & Co. He's the managing partner at Cloud & Co. and as well as the global head of Cloud & Co.'s occupational health and safety practice. He's recognized as one of the leading health and safety lawyers globally. And while he resides in Australia, his work is, as I said, truly global. He's acted in matters around the world and is often called upon to review the safety management systems of clients in a wide variety of industries. He holds a Bachelor of Commerce, a Bachelor of Laws with Honours, and a Master of Laws. And he's also a Fellow of the Australian Institute of Health and Safety and a recipient of its Lifetime Achievement Award. Michael has also lectured at Sydney University, the University of New South Wales, Australian National University, and the University of Auckland. And he has written and lectured extensively on occupational health and safety law and is an author and co-author of over 20 books. And of course, the one that we're most excited about is the one we've just published, which is Managing COVID-19 Risks in the Workplace, a practical guide. Michael, it's a pleasure to have you on.
Thanks, Craig.
And our final panelist is Jonas Blackmore. She's a legal writer, a senior legal writer in our practical guidance practice here at LexisNexis. She's a workplace relations specialist lawyer with more than 10 years experience practicing in the UK and Australia, and was most recently a senior associate at Johnson Winter Slattery in the workplace relations team, and has published extensively during her time both at JWS and previously when she was at Ashurst. Jonas, it's great to have you on as well. So just a quick introduction to the book, and then we'll ask a question of the audience, and then we'll get straight into the conversation, which I'm most excited about. So the book that we've recently published is co-authored by Mary-Louise and Michael, and it's called Managing COVID-19 Risks in the Workplace, a Practical Guide. And it's a guide to managing and navigating the myriad of laws, regulations, and public health orders in order to operate in a post-COVID-19 world. It's written both from a legal and an epidemiological perspective, which is exactly what this conversation is going to be about. And the book helps businesses with legal obligations and provides practical guidance in protecting the health of their workers, customers, and the public. And I know myself as the managing director for LexisNexis, this is a valuable, very, very critical guide, especially at this point as we start to come out of, start to unlock, and we start to actually work out how do we get employees back to the office. What are the risks that we have, both in getting them in and also if they happen to stay at home. So I'm very excited about that book and about this book now that's now been published. Okay, before we start, we'll just ask a polling question of the audience. So if you can pop that up, please. Will unvaccinated workers attend your workplace in 2021? Now note the answers are anonymous, so you won't be tracked. but it's going to be very interesting input for the conversation. So yes, they will be. Definitely not. We're not going to have unvaccinated workers. It's going to be their choice, and our business hasn't decided yet. So if you could answer that poll, that would be great. Okay, thank you. I'll drop the poll. Okay, so my first question, I'll throw it to you, Michael. Do you think a business can have a policy that mandates vaccination? Nice, big, open-ended question.
great question, million-dollar question. Well, the better question would be, does the business have a duty to mandate vaccination? Because we're actually looking at this in many respects the wrong way. We keep on asking the question, may I do it? But actually, the analysis requires you to work out whether certain workers in your workplace, because of the nature of their work, are exposed to greater risk to health and safety, where vaccination would be an appropriate control, and therefore a necessary control that should be mandated to protect them and to protect their colleagues in the circumstances in which they work. And surprisingly, the answer for many businesses will be yes. And indeed, some aspect of business operations, even if you're looking at the office environment, circumstances where people are returning to the office, the nature of modern ventilation and modern building standards and social distancing, etc., would mean that even in that setting, working in the office may actually require the business to think about very carefully about whether vaccination is necessary and therefore to mandate vaccination. Now, if you come to that conclusion that you have a duty to mandate vaccination or a duty to introduce vaccination as a control, and therefore, like any control, it has to be a mandatory control, then absolutely you have a right through the usual mechanism, which is to give a lawful and reasonable direction to comply with a policy which has been introduced for the health and safety of workers and others. And the status of that lawful and reasonable direction is fundamentally no different to the manner in which we enforce every other workplace policy, every other safety policy in the workplace, in that it relies on the same ability to provide a lawful and reasonable direction to employees to follow a policy. The flip side of that, not only do employees then have an obligation to comply with that lawful and reasonable direction, they themselves have a duty of care as workers. And that duty of care requires them to take reasonable care with respect to their own health and safety, with respect to the health and safety of others, which if you are performing high-risk work like healthcare, aged care, you have a high degree of interaction with vulnerable communities, that duty in its own right might actually require you to be vaccinated, which is an interesting part of the conversation that we don't talk about quite often. But in addition to that duty of care that workers themselves have, workers have a duty to follow the reasonable directions of their PCBU, their employer, their business, in relation to work health and safety, and follow the relevant policies that have been introduced for work health and safety purposes. And that's a statutory duty that is imposed on workers. Really, the whole system is set up precisely for that sort of risk management exercise to take place, for the decision to be taken in relation to whether a particular risk warrants a particular control. In this case, COVID and the type of work may warrant vaccination as a control, and then everything else follows from there. Now, in addition to all those things that I just mentioned, there are public health orders that apply across a growing number of businesses, particularly in Victoria and now Western Australia, Northern Territory, and those public health orders seem to multiply every day and seem to capture more and more workers as part of the ambit of mandating vaccination. And certainly if a public health order applies to business, they have a legal obligation to mandate vaccination in those circumstances.
It sounds like both from a potentially public health legal obligation, but also from an occupational health and safety duty of care obligation. Yeah, that's fascinating. Also a fascinating take to go from that angle. Mary-Louise, if for example we saw past that and we did decide to let unvaccinated people come to work, do I expose my fully vaccinated workers to greater health and safety risks?
Well, this is something that most people aren't realizing, that when you're vaccinated, you're really well protected after 2 doses from hospitalization, either with AstraZeneca or Pfizer, after you've had 2 doses, at about 95% against hospitalization and severe infection. And of course, death. It's really quite remarkable, but you are not protected against symptomatic infection. Now, we do know that your antibodies wane over a period of time after your 2nd dose. Now, we're not sure, and the leading virologists at WHO have provided us with some great updates on understanding whether or not it's mostly our antibodies or, of course, antibodies plus memory T cells that give us protection. Now, we usually only test for antibody levels, and antibody levels do fall, even with a great vaccine such as AstraZeneca or Pfizer. It starts falling at about 6 months. Now, on Monday night, the World Health Organization had another meeting, and we were presented with some very interesting information about if your vaccine started at, say, 80% protection level and then dropped dramatically because of Delta. If you have a 3rd dose, that gives you another boost of about 97% reduction of symptomatic infection. So you've now got booster issues as well. Should you encourage all your staff to have a booster shot so that they are not at risk of acquiring symptomatic infection or even mild and asymptomatic infection, and therefore in the workplace be able to inadvertently spread it to the unvaccinated? That's one of the problems. Or, of course, the unvaccinated spreading it to the double-dosed vaccine recipients whose antibody levels and protection levels are starting to drop. So it is complex, and you can get infection both ways. The unvaccinated can get infection, but they can also give infection as well, because they can have mild infection. You're in the workplace for many, many, many hours. As Michael alluded to, the ventilation may not be high enough to dissipate small particles, and people may acquire it. Now, it's at less risk if you're within that 6 months after having your 2nd dose, but it's so much less risk after your booster shot. So it places a whole new argument about whether or not you encourage your staff and bring the vaccine into the building to try to encourage them to have that booster shot as well.
Mary-Louise, I'm just noticed there's a question about quality of air in office buildings. So obviously we've talked about vaccination here, but there are other controls that I'm sure Michael will talk about and yourself. So having a Hepa filter or, a different ventilation mechanism in a workplace that isn't able to open windows, what's your take on that?
Look, the idea of how a Hepa filter works is really misunderstood. So can I just take a few minutes to explain how a Hepa filter is used, not by itself, but with multiple other infection prevention and control tools. We never use one tool alone. So you have a Hepa filter in a hospital that then is in an environment where it sucks in the particles, it takes out the viral particles from the air and then puts it back in. However, you've also got a high level of air change in, so you've got a second thing. The airflow changes at about 6 to 10 airflow changes per patient or person on that ward per hour. It's enormously costly to run, so you don't usually have it outside an infectious disease ward. And your air conditioning system in a big office building may never be able to ever get to 6 or 10 airflow changes per hour. Then they use it also with a negative air pressure room, so that when you open up the doors, any viral particles that have not had time to go through the HEPA filter don't go into the corridor and inadvertently infect somebody who's not wearing a mask. And the last thing they use, of course, is personal protective equipment, a mask and face shield. So you don't just rely on a HEPA filter to some magically way suck up viral particles so that you can work there and not wear a mask or a face shield, and not worry about anybody in the corridors in that shared space when you open up the doors, and it acts like a positive air pressure. So it's not going to help. It's going to look like it helps. And that's not good enough. And it'd be nice if you could open up windows, but that will be for the future. So you could do CO2 estimates to see whether or not you've got enough air, fresh air, oxygen coming in to that office and going all the way out. But really, it's not something that you should rely on.
That's really interesting, Mary-Louise. So obviously, everyone's talking about ventilation, but it's not the whole solution, and neither is vaccination. So, Michael, where do you think the position is at the moment then in terms of wearing masks?
Yeah, well, I mean, so if we just step back in terms of the conversation we just had, one of the things that need to instruct any controls that we have in place is the hierarchy of controls. Why am I raising the hierarchy of controls? Because the hierarchy of controls is designed to introduce controls that are more effective first, exhaust them, and then wherever there is residual risk, to then deploy lesser controls until you have minimized the risk so far as it is reasonably practicable. So your starting point in the conversation has to be, what is the most effective control that we can introduce in relation to COVID? And really, it has to be an elimination control where, and which is why we've sent people home where they can work from home. You minimize the number of people in the workplace. That way, you've got them at their home where they are safest. Now, if we're starting to return back to offices and to workplaces, that control then is not available to us, and we have to look at substitution controls. Well, there isn't really a good substitute for COVID. Sadly, it doesn't substitute for a lesser risk. It substitutes for one that spreads more quickly and seems to get worse as it goes through the letters of the Greek alphabet, and so we're really then left with an isolation control, and that isolation control in the context of COVID is actually vaccination. So that would be the start of the conversation, that you would actually need vaccination as a control if you have a situation where you have a large number of workers in an office environment with limited ventilation. Now, you then need to go through engineering controls. Ventilation is an engineering control. If you can, it's surprisingly, the solution actually for some workplaces might be simpler than the more technologically driven HEPA filters, type of approach. It's all about letting good airflow in, taking things outside where you can. Now, it's not going to work in an office environment, but it might work in a cafe or a restaurant where you actually take some of the patrons outside more. In a school where you take the students outside more in fresh air. And so ventilation can be used as an additional control in that way. Then you look at social distancing and cleaning protocols, which are all administrative controls down the hierarchy of controls. But within that, masks is the lowest order control. It's the least effective of the controls that we have in place. And one of the things that, although in certain circumstances we will be left with having to deploy them, one of the things that concerns me is that if that is the entire system that we're introducing, we will be very vulnerable to human factors because if you look at the setting where masks are used typically, It is in a healthcare setting where people are well trained, well instructed. They know how to don off the masks. They do it in combination with good hand hygiene as they do those things. They know not to reuse masks, not to put them in their pockets, not to put them on their clothes, not to wear them on their chin or around their ears or on their sleeves, as I see people doing. What I'm trying to say is that if the masks are being deployed as a control and we continue with the very bad practices, and I'll be interested in what Mary-Louise thinks about that issue, the bad practices that we have, it's not much of a control at all. It might actually be a vehicle for spreading the disease in certain circumstances, as you capture it on your mask and then you wipe it on your arm and you put it in your food and you spread it all over your clothes, etc. So really, we need the additional controls that are higher up the hierarchy to be used in combination and not as an alternative. They're not equals. You're not comparing equal controls in terms of effectiveness, and really, if you're down to the masks, then you're down to kind of that the last stubborn bit of residual risk that you're trying to manage as an additional layer of control to the other things.
Could I, while I've got you, and then move to Mary-Louise. Sorry, Mary-Louise, why we've got you talking about this, Michael. We have a few questions here coming down to number one, workers' compensation, and that both in terms of if someone has an adverse effect, or it may not necessarily fall within workers' compensation, but if that a person, whether they're fully vaccinated or not, goes out and then infects someone else as a consequence of catching COVID in the workplace, because obviously vaccination doesn't prevent someone catching it, or even isn't 100% on getting a serious disease. So how does that work? So both for the person themselves, adverse effect, or getting ill, catching the workplace, and then spreading it beyond that.
Yeah, there seems to be a misapprehension or a wrong focus in relation to the liability equation when it comes to mandating vaccination and liability. Mandating vaccination is a very net positive in terms of reducing your liability exposure. Let me explain. So there is some discussion about, if I mandate vaccination, does that mean if someone has an adverse impact from the vaccine that I may be liable for it under workers' compensation? Well, notionally, yes, because it's an injury that has arisen where workers are substantial contributing factor. So notionally, the answer is yes, except for this. There's an indemnity scheme that kicks in at mere $5,000 where the government indemnifies the injured worker, injured person, in relation to any adverse effect of the vaccine. And you simply apply, you say, I've had an adverse effect to one of the approved vaccines, the 3 approved vaccines, Moderna, AstraZeneca, and Pfizer, and you're automatically compensated in relation to any loss or damage over $5,000. The only thing you had to show for the claim is that you spent a night in hospital for from 5,000 to 20,000. The criteria hasn't quite been settled in relation to over 20,000, but it includes loss of wages. It includes everything, right? So notionally, you have an exposure to less than 5,000 or less in relation to an adverse impact. Now, bearing in mind, the likelihood of an adverse impact is very small, and you have an exposure that's capped at $5,000. Now, look at the reverse. What if someone catches COVID at work? Is it compensable? Yes, absolutely. It's an injury that arose from work or work as a substantial contributing factor. And in those circumstances, any injury that arose during the course of employment, which is COVID-related, would be compensable under workers' compensation. Now, people say, well, how do you prove it? Well, genomic testing and sequencing shows who patient 0 is in relation to any outbreak. So it will not be very difficult to prove where COVID came from or where the person has got COVID. currently, as we sit here, all the essential services have been deemed to where workers acquire COVID. The assumption is that they've acquired COVID at work, and it's a rebuttable assumption by the employer in those circumstances. So at least in relation to the essential services that have continued to operate before the economies have opened up, there is a presumption that COVID was acquired at work, and it'd be interesting to see how that shifts over time. No doubt it will. But what I'd suggest to you is that the evidentiary hurdle that needs to be overcome, whether COVID was acquired at work or not, is not that difficult to overcome for workers. And therefore, if you have a policy setting that increases the likelihood of people getting COVID, then you're exposing yourself to very significant liability on workers' compensation. Now, workers' compensation is at least an insured risk. Let's talk about if you have a public-facing operation as a workplace or retail setting, for example. You have customers coming in. You have a restaurant, a bar, a club, even an office situation. We have clients attending, and you have an office function, for example. What if you have an outbreak because you have unvaccinated people in the workplace and they have carried COVID and then have provided COVID to those who attended the function or were at that bar, etc. Could you be liable in those circumstances? Well, the question will be, did you discharge your civil duty of care? Did you take reasonable care with respect to the health and safety of those who have attended those premises? And then the scrutiny will be around the whole myriad of questions that we were talking about in terms of the hierarchy of controls and the mix of controls that you have put in place. Now, obviously, if you've got a vaccinated-only workplace, you're going to be in a better position to make an argument that, I've at least live in that space. In addition to that, I've done additional things like cleaning arrangements, like social distancing, like putting hygiene stations in terms of sanitizer, etc. And I took reasonable precautions in that respect. Or I looked at ventilation. I looked at those questions. But if you remove certain controls randomly, and I mean randomly from the mix of controls that you have, then you're in a much worse position trying to justify you've taken reasonable care in those circumstances. Why am I saying randomly? Because ultimately, the decision to remove that control tends to not be scientifically based or risk-based. It tends to be what I'll call driven by a particular view, social view, or perception of what the right thing to do is, that is not underpinned by legal analysis. And that then exposes the organisation to, in my view, unacceptable risks in those circumstances. So you've got then the civil liability. Now, the last bucket of liability that no one's talking about is this liability in relation to prosecutions by health and safety regulators in relation to breaches of the duty of care under work health and safety legislation. Now, most regulators, if you ask them right now, say, "Oh no, we would never do that." But then they would say that, wouldn't they? I mean, every regulator says we would never do that until there's a major outbreak, and then hundreds of people die, and then the public pressure in relation to actually doing something about it far outweighs their desire not to interfere in business considerations. And really, all regulators come to the task of prosecution reluctantly. In fact, they have an enforcement hierarchy that suggests that is the model they wish to adopt, in that they don't wish to prosecute as a matter of course. They wish to educate, they wish to encourage, they wish to use lesser enforcement techniques like notices and the like to encourage voluntary compliance by the regulated community. But when do they enforce the law? In two circumstances: where someone has reckless disregard to the law, or in circumstances where the consequences are far too great and there's a public outcry. Now, the case in point at the moment that's playing out for all to see is Victoria in relation to Victorian hotel quarantine, where you see I think it's 28 charges have been brought against the Department of Health in relation to their conduct in relation to that particular quarantine exercise. And full disclosure, both Mary-Louise and I had an involvement in relation to that inquiry in relation to one of the parties, but not the party that's been prosecuted. In a sense, you look at it and you say, well, there's an exposure of about 95 million in potential penalties arising from a mismanaged quarantine arrangement, where essentially the allegation is a breach of duty of care because of systemic deficiencies that have been introduced or failures in relation to how that particular workplace was set up for contractors, for members of the public, etc. Fundamentally, that picture is not different to what the picture would be or down the track if there was an outbreak. Now with vaccination as an option, an equivalent number of deaths. Remember, 800 people or thereabouts died in Victoria as a result of the outbreak, and so the pressure will be on regulators. What are you doing about this? Outrageous situation, this catastrophic incident, and inevitably, if they're doing their jobs, which they all do, and they're all diligent in doing so, they will cave under that pressure and bring prosecutions. Now you're talking about very significant penalties and importantly, uninsured risk. Now, what's the downside then to introducing vaccination? While people say, what if people make a claim? It turns out that the balance of legal rights is not in favour of people resisting a vaccination mandate where the risk assessment justifies it or public health order mandates it. But the balance of rights are in favour of vaccinated people who refuse to work with unvaccinated people because that situation, and Mary-Louise eloquently provided the analysis in relation to that earlier in answer to your question, Jonas. They may have a concern about whether there is a higher degree of risk of getting COVID and spreading COVID to loved ones, particularly vulnerable loved ones, as a result of being in a workplace where that is open to unvaccinated people. And they have a right to cease unsafe work. They then have to make themselves available to do alternative duties, alternative safe duties, but there is continuity of their employment during that period. So therefore, there are protections afforded to them in relation to their decision to cease work that they regard to be reasonably regard to be unsafe work, and then it needs to then be resolved through either the dispute resolution mechanism or by the introduction of a safe work inspector in New South Wales or the equivalent in other jurisdictions to mediate and resolve the dispute and therefore issue notices to either determine whether the workplace is safe or unsafe in those circumstances. And during that period where there is a dispute and you're trying to resolve it, the person continues to be paid and enjoys the full gamut of protections of anti-victimisation provisions. Not introducing a vaccination program where vaccination is warranted is an absolute liability nightmare for employers. And really leaving aside what you would like to do, the legally prudent thing to do would be to risk assess and decide whether vaccination is required and then introduce vaccination if it is required. Now, I say risk assess and determine whether vaccination is required because that risk assessment is going to be your best friend. If a proper risk assessment determines that vaccination is not required, then you would have the answer to the worker who says it's unsafe, and you would have the answer to the litigant who says you didn't do everything reasonably practicable,
or they even take reasonable care with respect to their health and safety. Workers' compensation is workers' compensation, but you would reduce the likelihood that a claim is made, and then that becomes your legal strategy. But in the absence of that move, that you haven't done what you should be doing.
Oh, that's great.
That's a great sort of thing, because the next question on the list, sorry, Jonas, I'm jumping in, because the next question on the list, you're talking about risk assessment. And there's a question here for Mary-Louise. Does an unvaccinated infected person pose a greater risk because they're likely to have a higher viral load than a double vaccinated person, which probably goes to the heart of that risk assessment?
Yes, Greg, that's a great question. And yes, they will have a higher viral load than somebody that's been double vaccinated or triple vaccinated, absolutely. And being in the workplace for many hours, if it's indoors and not in a hospital and not in an infectious disease ward, then increases the likelihood that they will, of course, breathe it out. Now, this is where you couldn't expect everybody to wear a mask for 8-10 hours a day straight. It's really hard work. And, we've had many healthcare workers around the world acquire COVID, not just during social events, but at work. And these are experts in wearing masks. And even they forget when they're in an environment of a war against COVID, they will inadvertently pull their mask down, take a drink, talk to somebody doing, the clinical handover, and acquire it on a COVID ward or from another healthcare worker who's in that early stage. So if you're a non-healthcare worker, it's going to be very hard to ensure that you wear it without touching it. And, Michael mentioned important layering of, the hierarchy of prevention. And there's masks and there's hand hygiene and there's lots of other things. And you would have to ensure that all of this is done all together. And that's very difficult. So then you'd have to bring in, if you can't mandate vaccination at the workplace, using a rapid antigen test. Now, rapid antigen tests have had an unfair reputation over the last year when several of us have been trying to get rapid antigen testing to augment PCR testing, which is diagnosing, where rapid antigen tests in a country like ours would just be used to screen and identify, are you safe to come to work? If you were going to use rapid antigen tests, you'd have to use them preferably every day, because while most of them that have been TGA approved in Australia have something called at least 98% specificity, in other words, that accuracy of identifying you as truly negative, once you start testing every day, that goes up dramatically to something like 99.999% accuracy. So they've been really given a bad rap. So they are good. However, you would have to test not just those who are not vaccinated, but you'd have to test those who are vaccinated unless they have their booster shot, because as mentioned before, they could have an early but low level virus load, and they could still be a source of infection to the unvaccinated. And Michael will talk then about duty of care. So, they're about $10, $15, $20 each. Now, fortunately, TGA has removed the need for a medical or a health practitioner to facilitate the rolling out of those, because quite frankly, women and teenage kids, girls have been using very similar ones, and they look like this. They're very, very simple, and they're very easy to do. You don't need a professional to help you do it. However, you would need somebody to help roll it out, be it the WorkSafe professional, the appointed staff at work. But that would get expensive every day. And then, who's going to cover that? And, Michael would best talk about that, because, the government protects us brilliantly with vaccines and with a booster, which is great news. But they don't financially support organizations yet, sadly, to augment this control of COVID while we get back to work with reducing the cost.
Mary-Louise, I can see that, and thank you everyone for your questions. They're all great. So we're trying to get to them all. Adam has talked about preventative controls before you enter the workplace. So putting aside vaccination here, and whether it would be effective to do temperature measurements and, as you pointed out, then the rapid antigen testing, which the tests I think are going to be at Woolies, and other kind of screening practices. What would you recommend there?
Yes. So first of all, temperature checking is really public health theatre. It's great. It makes you look as if, and you're sending a lovely message, I'm taking this seriously, I'm going to look after you. But not a lot of people elicit a temperature. And certainly with Delta, we have learned compared to non-Delta that you are highly infectious before your symptoms, and fever or temperature increase is a symptom. And so you are highly infectious to people before you even get a temperature, if you ever elicit a temperature. So that one's going to be no use. And anybody that uses them, it's great theatre, but don't expect to find somebody, because you're selling this story that says, I'm watching you. So then you'd have to ensure that people come to work, if we're talking about layering, if there was high circulating virus, such as there is at the moment in Melbourne, and you wanted people to come back to work or to retail, make sure they wear a mask that is triple layered or a surgical mask. And it's very difficult if it's not a surgical mask to tell whether it's wet. Once it gets wet and moist, it stops working. And doctors and nurses understand this, and they change their masks regularly if they're not already changing it because they leave the ward. So offer the masks on in the workplace, overtly remind them to change them regularly, and hand hygiene. But certainly rapid antigen testing is a very good way of trying to reduce that risk for workers. But once you start having customers come in and they're not wearing masks, then that's very difficult. But if they're double vaccinated, you've got less of a risk, but testing them for their temperature isn't going to help.
Well, one other question, actually, Mary-Louise, sorry, Greg, is someone's asked something you've all asked interesting questions, everyone. But what about a situation where you have an unvaccinated worker who has had COVID? What about after that, their own antibodies?
Are they protected? It's a very interesting question.
And what do you do? Like, can how does that fit within this whole, like, you're vaccinated, unvaccinated? Because obviously they're in the middle.
No, it's a nice question. So at WHO, we had several months ago groups providing us with information where we were looking at what to do for infection prevention and control. And one presenter, who actually comes from the Kirby Institute at the University of New South Wales, I'll just plug that, showed his work, Miles Davenport's excellent work, and his team at showing that, your antibody levels start waning at about 6 months. Well, actually, sometimes even earlier. And certainly with a natural infection, you don't have a lifetime of protection. That lifetime may only last anywhere between 3 and 6 months. The CDC in America, the Center for Disease Control, that used to be the leading Center for Disease Control in the world, we've all gone there to learn, they tell people in America that if they've had natural infection, to get vaccinated at 3 months after they've got better. Now, talk to your GP to make sure that you really are well enough. But basically, that's saying your antibodies are at a level that look as if you're susceptible. Now, just one more thing. Antibodies aren't the only way that we fight this virus. We fight it with what's called memory cells. And we don't know if those memory cells will come out of hiding and fight the good fight. But and we only ever measure for antibodies. However, there have been great studies done even before Delta that said that if you've had natural infection, you're more likely to get a second infection than anyone that has had, one or two vaccines. Now, that could be biased because of where you're living, high level of high density living, risk issues, like you might work in a hospital. All of those confounders have not been able to be controlled for, but it could be a physiological issue. We don't know. So, short answer, get vaccinated. Now in Australia, it's 6 months after you've probably had the infection, or 6 months after you've had your last second dose. That's not going to save you from bringing infection into the workplace. You're not going to receive a lifetime of protection after a natural infection, sadly.
Presumably you'll have an exemption for a period in a mandating policy. But we'll go just 2 more questions for you, Mary-Louise, while we've got you on this. So this is really drawn from our questions, but basically, we hear a lot that like COVID's going to become the new flu. Like, how does COVID sit with flu in terms of comparing those two viruses?
Wow. Well, first of all, flu vaccine. Well, we haven't had any deaths for flu this year. Amazing. And last year, Australians rushed to get the additional flu doses that the government procured for us. And so we had very, very little flu last year as well. The people who die from flu are normally the elderly and babies, little kids as well. They don't have any memory for any antibodies. So how do they compare? Well, the vaccine uptake for influenza, particularly in the elderly, is good. It's not perfect. It's around about 70%. Fantastic. And I'm hoping that we have all learned that we need to have the flu injection at the same time as we have our COVID injections next year. And that the workplace may offer that as well. Because young people, as soon as they leave home, they don't have a GP anymore. And it's the GP who will say, I'm writing you a prescription. Oh, would you like a flu vaccine with that? So every May, you need to start thinking for yourself, because we've moved from a public health protection from the authorities to very much an individual protection. And you need to keep flu down, because we were really worried last year we were going to have a dual pandemic of flu and COVID, but we did not, because our government really protected us by providing more flu vaccine. So I hope that explains it. I mean, it's impossible to try to say the diseases are similar or dissimilar, because not everybody gets a laboratory-based diagnosis for flu. So it's very difficult to give you an idea of how many people suffer flu, how many people die from flu with the true denominator or get admitted. But certainly during pandemic influenza, we saw the elderly were okay because they had a memory of the virus, how it changed. But it was certainly the young age and the pregnant women who did very badly.
Oh, gosh, there's so much to ask here. But I guess since we've been talking about the vaccination, Michael, what's the position in terms of, we've got our lovely risk assessment and we've included our vaccination as a control. Well, how do we record that if someone says, no, you can't record that I'm vaccinated? In terms of Privacy Act, etc.
Absolutely. Yeah. So there's 2 things you need to navigate once you've done your risk assessment and you develop your policy. 2 additional considerations you need to work your way through. Well, firstly, before you get to those 2 considerations, remember whatever policy you introduce, including the risk assessment itself, needs to be done with the engagement of the workforce, because there's a duty to consult workers in relation to matters affecting them. And where programs have been challenged, they typically have been challenged in relation to lack of consultation. So just remember that if you're introducing a mandatory vaccination policy, that consultation is your friend here, because it actually will make not only introduce legal compliance, but also will make the journey of ensuring
that you get the take up from the workforce much more effective. But then the two considerations you need to work your way through is discrimination law and privacy. So on the discrimination front, your starting position is to create an exemption where there is a protected attribute. What are the more obvious protected attributes? Disability, which is really a medical condition. So in that context, it's a medical contraindication. So where someone's got a medical contraindication, and they need to create an exemption regime for that. All mandatory vaccination programs introduced by companies or public health orders have created an exemption in relation to medical contraindication. But it has to be truly medical contraindication, right? It's not I don't like it, I don't want it. It's medical contraindication by a practitioner. Now, the discrimination law is not as restrictive as what the public health orders have said. They've given a very short list of what is permitted, but actually any ground of discrimination, which is any medical condition, could give rise to an exemption in that context. The second is religious exemption. They're the two obvious discrimination grounds that you need to cater for. And what we recommend is people take an evidence-based approach to that exemption regime. Now, in addition to that, you need to navigate the privacy considerations. Now, a lot of people think that it's a much easier route to skip the risk assessment and go down the privacy considerations, find out which, how big a problem is this among workforce, et cetera, et cetera. Actually, not allowed to do any of that because unless and until you've determined that vaccination is going to be a control that you're introducing in the workplace, you don't have a legitimate reason to actually ask the question in relation to what is a sensitive health information. The second thing is you will need consent in relation to collecting that information. So either justification, justifiable business reason, and you need consent in relation to collection of that information. And what we recommend people do when they're introducing a mandatory vaccination policy is that they do a mini privacy statement where they deal with the question of consent, where they deal with the question of the storage of information, deletion of information, and what they intend to, and when the policy will expire, so that you can provide adequate security in relation to that, the collection of that information. And then the final point in relation to privacy is applying the minimization principle, where you actually minimize the amount of information that is collected. Now, Victoria stands alone in requiring particular information on the public health order to be collected in terms of the date of the vaccine and the person who has cited the person who has cited the evidence and some, I think it's the date of vaccine as part of that. But most jurisdictions don't have that requirement, which means that really what people are relying on is a mechanism by which you cite the medical certificate from Medicare, which is typically a digital form certificate. You cite that, you put a tick against the person, or as a number of our clients have done, deactivate their passes and then reactivate them once you've verified the information. And then you have a very simple solution for making sure that only vaccinated people enter the workplace, if that is your policy in that context. And then rely on the policy in terms of communication. So don't say, this person is vaccinated, this person is not. Respect people's privacy in relation to that. Interestingly, in New South Wales, yesterday, a public health order was introduced, making it an offence to falsify a vaccination status. So clearly that had
I was surprised it wasn't an offence already. That was my surprise.
Yes. Well, I mean, it's certainly it's arguable that that it would have been, and it's arguable that certainly as a matter of workplace policy, lying to your employer in relation to something which is a policy that they have would actually be not an offence, but a breach of a stackable offence, for want of a better description, something that would be subject to disciplinary action in terms of summary dismissal. And so, but in any event, it is now, as part of the public health order, an offence in its own right. But please don't forget privacy. Please don't forget discrimination, and really underpin all that on a risk assessment that looks at the question and looks at it holistically. It's not just about vaccination, but vaccination is an important part of the conversation. Jonas.
And I presume this is well covered in the book, because obviously how you do that risk and how you take, yeah, that's good. I might just switch quickly to the polling results, because we've got very interesting polling results. So as you recall, we asked, will unvaccinated, well, there you go, they just popped up. Will unvaccinated workers attend your workplace in 2021? Interesting mix there. So 23% say yes, they will. 14% is their choice. So clearly a large minority are saying that they will have unvaccinated workers, and then definitely not 38%. I'm just wondering if that's going to have shifted based on this conversation. Very interesting conversation.
So I think there's also some other interesting questions in there. Ian's asked us about refusing services to non-vaccinated patrons. So to my mind, and obviously guided by you here, Michael, you know, unless there's some discriminatory protected attribute, obviously vaccination isn't one of those, you're probably entitled to refuse services. But I also think, and please go there on that, there is also an issue here about the person who's actually, you know, having to refuse that service in terms of protecting their mental health in this situation where people can actually, you know, get pretty upset and maybe aggressive in those circumstances.
Yeah, there's look, a few things run through my mind on the second question. I'll come to that, and forgive me, I might take a little bit longer on unpacking that second point. The first point is very simple. Unless it's a protected attribute, then you're perfectly entitled to decide whom you serve and the terms and conditions on which people enter your workplace. That's pretty clear, pretty settled. People throw bandy words around, and let's be clear here. These are not policies that are introduced without foundation. Currently, they're introduced under as a legal obligation under public health orders. If a business decides to maintain them going forward past 1 December, and certainly I strongly recommend that every business consider that question. I'm not saying that they necessarily must come to the conclusion to maintain it, but I strongly recommend that they come to their conclusion with their eyes wide open after a risk assessment that looks at the adequacy of controls in those circumstances. Then they will be doing it because of an underpinning safety reason. Obviously, there was good reason why you are introducing that policy. But quite frankly, a business in New South Wales has decided that they will only allow unvaccinated people in their workplace, and they will exclude vaccinated people. You know what? They're perfectly entitled to do that. If they decide that the only people that can enter their workplace is unvaccinated people, so going against the grain, the opposite of what everyone else is doing, they're perfectly entitled to that. And it's no more discriminatory in that context to do that than it is to restrict access only to the vaccinated. Now, let me come back to the question of...
I'm just going to call time. We've only got 2 minutes. So if you can do 1 more minute, I just want to do the book at the end, just to remind people of the book. Thanks.
Yeah, absolutely. Yeah, sure. I'll be very brief. Absolutely, we should protect the mental health of people who are having to enforce those rules, whether it's company rules or public health orders. Just remember that a person at someone else's workplace has a duty of care and has to follow the site rules in relation to that site. It's a criminal offence. It's a breach of the Work Health and Safety Act, attracting in extreme cases 5 years imprisonment to fail to do so. And what I strongly recommend that, in addition to calling the police in relation to those individuals, that people call the Work Health and Safety Regulator. It is my strong view that the Work Health and Safety Regulator should be pursuing those matters and should be prosecuting those matters, because these are typically young workers who are being subjected to abuse and risk to their psychosocial health in very unfair circumstances. And I think we all should be trying to do our best to protect those workers.
Yes, completely. This has been a fascinating conversation. I think we're going to carry it on at least another hour. Just a reminder of the book. It's called Managing COVID-19 Risks in the Workplace, a Practical Guide. It's published by us, LexisNexis, so you can get it on our e-store or from other book distributors. So please do have a look at that book. I think there's a lot more detail. There is a lot more detail in the book. It's been fascinating and awesome to have both you, Michael, and you, Mary-Louise, and great also Jonas, who's a deep expert on this as well inside our business. The two quotes I get from this: public health theatre. I love that quote from you, Mary-Louise. And Michael, just your consultation is your friend. Clearly there's risks here, and it sounds to me like consultation is a really good way to go as well with your employees. Thank you so much. Awesome webinar. Thank you, everybody.
Thank you. Bye.
My pleasure.